Hello, my name is Luca Ferasin, and I'm one of the cardiologists at the Valve Veterinary Referral Center in Marlow. I'm here today to talk about coughing in dogs. And although I'm a cardiologist, and so I work primarily in this field, I always had a strong interest in respiratory medicine, in particular about coughing. And I've been studying coughing for many years and published extensively on this topic. So I would like to share with you my experience, my knowledge for this very common clinical presentation in first opinion practice. First of all, I would like to disclose the fact that I do not have any conflicts of interest in relation to the content of this presentation. So let's talk about coughing. And what is coughing? Coughing is a beautiful protective mechanism that we have and all our patients have to protect the airways. So if something is trying to enter the airways, like a foreign body or gas that can be dangerous, then coughing will try to remove this potential risk from the respiratory system. And this starts with the stimulation of coughing receptors. Coughing receptors that we will see in a minute are located differently along the airways. When these coughing receptors are stimulated, they evoke a series of mechanisms that are characterized by a deep inspiration initially in order to expand the volume of air in the lungs, followed by a very forceful compression or expiration against the closed glottis. Because the glottis is closed, then the pressure, intrathoracic pressure, will increase to high levels. And so when the glottis eventually opens, we got this very forceful expiration with this explosive maneuver with a typical loud sound that characterizes coughing. So it is a beautiful reflex that will keep our airways as clear as possible. When these receptors are stimulated, the stimulus travels through vagal fibers to the brain, where there is a center of coughing. And then these stimulus will be elaborated by the brain and will be eventually responsible for triggering the motor action that causes all the different phases that we have just seen in the previous slide. So let's see where these receptors are, how these receptors work and when they are located. So as I said before, this stimulus travels through the vagal nerve. And the coughing receptors, the majority of coughing receptors are the so-called rapidly adapting pulmonary stretch receptors that are termination of a vagal fiber. And they are located under the endothelium of the respiratory mucosa, but also under the smooth muscle cells that characterize the structure of primarily the major airways. So if there is a stimulus that affects the mucosa, like a foreign body, let's say, for example, that is penetrating the airways, that will cause a mechanical compression that stimulates these receptors. And similarly, if we have bronchospasm, for example, that can stimulate the coughing receptors. We will see later that bronchospasm in dog, or spontaneous at least, bronchospasm in dog is not possible, and therefore this primarily applies, this important mechanism primarily applies to cats, which on the contrary have a sort of predisposition to bronchospasm in feline asthma. So when these fibers are stimulated, these receptors are stimulated, then the signal travels through the vagal fibers and goes to the brain. They're located, as I said before, primarily in the upper airways. And these mechanoreceptors are in high density at the level of the larynx, the trachea, and large bronchi. And as I said before, the function is primarily a response to a mechanical stimulation, so they're mechanosensitive. Probably the vocal cords represent the highest density of receptor. It makes perfect sense, because if you have a foreign body trying to penetrate, that will be the very first point where the sort of protective mechanism will intervene. When we travel down the airways, we go, for example, to bronchi, smaller bronchi, then we got less receptors, so there is a lower density, and they start becoming more chemosensitive, which again makes perfect sense. So if we have, for example, inhalation of gas, it's very unlikely that this gas will stimulate the mechanoreceptors in the larynx or trachea. So these are receptors located lower down in order to provide the coughing reflex to also expel gas that should not have entered the airways. But also important, very important, is to remember that in the very low airways, so smaller bronchi, bronchioles, or even alveoli, we do not have coughing receptors. So we cannot initiate a coughing reflex from these areas. So if the receptor is being stimulated, then the message will travel through the vagal nerve, that we can see coming here from the bottom left, and goes to the center of coughing in the brain, in the medulla, probably very close to the respiratory center. I say probably because the anatomical location of this coughing center has not been clearly described. But I say close and not the same, because we can either cough or breathe. So the respiratory center cannot be the coughing center. They're probably located in proximity at the level of the medulla. And you can see that here at this point, we got the stimulus that could potentially trigger a coughing reflex. And this will happen when the stimulus is strong enough to reach a certain threshold. A threshold that is not fixed, but for simplicity at this point, we'll try to imagine this as a single value that needs to be reached in order to evoke coughing. And the strength of the signal depends on the number of receptors that have been stimulated. But it's not that simple, because we do have sort of influence from the cortex. So we know, for example, that we can cough voluntarily. We can also try to inhibit cough voluntarily. And everything is determined by messages sent by our cortex. Placebo effect is also very similar. This is something that they notice when they run clinical studies to test, for example, a new antitussive product. They very often notice an improvement in clinical signs, even in patients receiving placebo. And that's because, again, it's the cortex that can have this effect or inhibitory effect at the level of the coughing center. So these are primarily negative effects or negative influences coming to the coughing center. Similarly, the endogenous opioids can reduce the likelihood of coughing. And we know that when we use exogenous opioids, if we give, for example, codeine or butorphanol, then again, we add a negative feedback to this center. So in other words, when we got the sum of all these positive and negative stimuli, if we still have enough stimulation coming from the receptors, we might be able to reach that threshold. If we reach the threshold, then it will be the recruitment of all the muscles responsible for that deep inspiration, forceful expiration, movement of the glottis, and so on. Now, this is very important to remember, because then we will talk about the tracheopalpation, how we can evoke cough in our patients. So we need to remember this mechanism to understand exactly the meaning of a positive tracheopalpation. So the stimulus goes to the motor action that will cause, if the threshold is reached, we can have that typical explosive maneuver that will expel the potentially noxious material that has entered the airways. Here I've got two examples of coughing dogs. On the left side is a dog with chronic bronchitis, which by definition is a chronic inflammation causing excessive production of mucus that tends to stagnate in the airways. Also because there is a concomitant dysfunction of the mucociliary escalator, so this mucus tends to be stagnating in the bronchi, and it becomes a little bit thicker than normal, so it needs to be expelled. Otherwise, these dogs will simply die. They will asphyxiate on, with their own mucus. So that's where the typical cough reflex originates from. It originates from the bronchi, and this is a no Labrador with chronic bronchitis. You will see will have a very deep inspiration followed by forceful expiration. Also, please notice in the video the fact that after each cough, the dog swallows. You may have heard a typical sort of wet sound because it's a productive cough due to the mucus that is moving following cough, and the dog swallows because this mucus then reaches the pharynx and has to be eliminated. Right, on this side here, we got a puppy with kennel cough, and this is a slightly different presentation. The dog coughs in bouts, and the cough is not preceded by deep inspiration. Let's see the video, and then I will explain why. You see, there is very little inspiration following this battery of expiratory efforts, and that's because kennel cough, which is affecting this puppy, is primarily an inflammation of the larynx and trachea, so it's a laryngotracheitis. Now try to imagine a foreign body entering the airways. The very first point of contact with the airways will be the larynx and the trachea. So if there is a stimulus at that level, the last thing we want to see is a deep inspiration, because that would increase the risk of inhalation of a foreign body. So that's why the dog with chronic bronchitis has a problem starting from lower airways, and it needs a very deep inspiration in order to produce a forceful expiration and remove this material from the bottom of the airways, while the puppy will have these typical bouts of expiratory efforts, which is typical of the expiratory reflex. So for simplicity, we call both of these presentations cough, but if we appreciate the different presentation, we understand if the problem is originating from upper airways or lower airways. I mentioned briefly before the importance of tracheal palpation. So it's not a yes or no answer as very often interpreted. So it's not a positive tracheal pinch or a negative tracheal pinch. That's not the case. It's the answer to this test is how much effort do I need to put on my pressure in order to evoke cough? Because if we have a normal patient, we probably need a lot of pressure to reach the threshold. If it's a patient already with stimulation of the coffee receptors because of a chronic bronchitis or a chronic airway disease, inflammation, and so on, then the palpation will be very gentle. In order to evoke cough, we just need a very gentle palpation. And I always recommend to have the stethoscope ready, so position on the chest of the dog, so we can listen to the lungs while the dog is coughing, because sometimes if the mucus is very thick, very tenacious, it tends to not to be heard on normal auscultation, but with a forceful movement of air in the airways, it may unplug and we can hear the typical sound of mucus moving in the bronchi. So that's how we do it. It's a very simple maneuver. Very simple maneuver because we just press side by side simultaneously the first or second tracheal ring. And you may have noticed that this dog is not showing the typical cough reflex, it's more of an expiratory reflex, and the reason is still the same. Physiological explanation because it originates from upper airways, from larynx and trachea. I know we're talking about dogs here, but just want to show you a tracheal palpation of a cat. Sometimes cat can have a hybrid response, which is a mixture of coughing and sneezing. And the reason is that they also have sneezing receptors. These animals have sneezing receptors in the trachea. So by doing tracheal palpation, we may end up with this bizarre sound, which is a mixture of coughing and sneezing. Okay, so let's move to this diagram, which is a very interesting study that has been performed in people, but helps understanding the concept of the threshold for coughing. If we look at the first bar, the control group needs a lot of stimulus in order to have a cough. The stimulus here is done with capsaicin, which is a chemical compound present in the red chili pepper. And that's why sometimes when we eat something very, very spicy, we cough. That's the mechanism. But you see that we need a lot of stimulus in the control group, which are healthy patients, in order to see cough. But then we got here a group of patients that have predisposition to cough. Could be idiopathic cough, could be asthma, or could be a gastroesophageal reflex. And you see that the stimulus is much lower in these three groups because we got already stimulation of some coughing receptors. So that again is another confirmation that the stimulation of cough with tracheal palpation, for example, is not a yes or no answer. It very depends how much effort we need to induce the response. So in other words, sometimes we got dogs that got a lot of stimulation, got airway disease, and then we add very little extra bit, like the last straw that breaks the camel back, in order to induce coughing in these patients. For the same reason, I can induce coughing pressing on the chest. We got coughing receptors in the chest, and therefore there's another way to do it, as long as we don't cause any discomfort, of course, to the patient. So this is a geriatric dog. She's got chronic airway disease, and you will see that my pressure on the chest will induce cough. Now, let's try to do an experiment. This is something I've done a couple of years ago, and I simply Google common causes of coughing in people, because this will explain a lot about the so-called cardiac coughing that we believe to see a lot in our patients. And that's the result of our search. Most common causes of chronic cough are post-nasal drip, asthma, the gastroesophageal reflux, very common cause of cough in people, chronic bronchitis, and then we carry on with some other information from other websites. We can have obviously infections, we can have blood pressure drugs, can cause ACE inhibitors in particular, can cause coughing, chronic bronchitis, and post-nasal drip syndrome, which is a very interesting mechanism of cough in people. Again, one of the most common causes, together with the gastroesophageal reflux. Do we have post-nasal drip syndrome in dogs? We do. We do. It's probably very under-diagnosed, and sometimes because simply we don't know it. And I've got an example here of a dog that had post-nasal drip syndrome. So basically, this is a chronic rhinitis or rhinosinusitis that causes a percolation of fluid, of exudate, that percolates in the pharynx, and then it goes, and this material can touch the opening of the larynx, so the laryngeal folds, and goes in stimulation of the mechanoreceptors at that level. So when we have a dog with excessive swallowing, coughing and sneezing, and perhaps with evidence of some also nasal discharge, that could be a possible patient with postnasal drip syndrome. As I said, poorly described in dogs. But this is a nice example. This is a 14-year-old whippet that had a 1-year history of excessive swallowing, chronic coughing, occasional sneezing, typical presentation of or typical condition that can cause postnasal drip syndrome. But this dog also had a heart murmur with a point of maximum intensity of the left apex and was treated with furosemide, pimobendan, and benazepril because the attending clinician was concerned about congestive heart failure because of the murmur and the cough. In reality, you can see the X-ray here in the middle. There is no evidence of cardiomegaly. So the murmur is probably associated with the mitral valve disease, very early stage. There is no ventricular enlargement, no atrial enlargement. There is nothing wrong with the lungs, perhaps with the only exception of an opacity that at the middle here of the chest that might be consistent with a degree of pneumonia. But anyway, the diagnosis in this case, due to the history, was postnasal drip syndrome. And this dog had all the other drugs removed. So furosemide, pimobendan, benazepril were discontinued and had therapy with ultrasound humidifiers, a very simple therapy that will make the mucus a little bit more fluid in order to make the stimulation of the larynx less important, and therefore with less stimulation of coffee receptors and less cough. Indeed, this dog responded to treatment within a week and did not cough for the following 2 years. This dog was put to sleep at the age of 16 due to a renal tumor. So you see that this dog could have had a much lower or a much shorter life expectancy if it was continued with drugs that were not needed, especially with the furosemide that would dehydrate the patient, where the actual therapy is the opposite, is based on hydration, not dehydration. So very important cause of cough that we need to remember. As well as the gastroesophageal reflux, which again, one of the most common causes of cough in people and very neglected in our patients. Nowadays, especially in brachycephalic dogs with brachycephalic with upper airway disease, obstructive disease, perhaps this is a little bit more recognized nowadays, but really probably underestimated in the majority of cases. And the mechanism, again, is not 100% understood, especially in our patients, but it's probably something to do with the sensitivity of the coffee receptor to the acid that is regurgitated, and also with the mechanical stimulation of the gastric content itself at the level of the larynx, if you can reach the higher part of the airways. This is a story of a 9.5-year-old female staffy that had 2-month history of retching and coughing. Again, the red herring was a heart murmur with a point of maximum intensity of the left apex, most likely due to mitral regurgitation. This dog didn't have, again, any significant heart disease, but was treated initially for heart failure. You can see all the attempts to treat cough in this patient with benazepril, furosemide, and theophylline, butorphanol, and then went on with benylin, clamoxyl, ceforex, Bytro, metronidazole, and then steroids, always the last resource, and then fenbendazole, thinking about potential lungworms. In reality, you can see this dog had a gastroesophageal reflux, and you can see the gastroscopy, the images from the gastroscopy show inflamed mucosa, probably also an ulceration of the level of the cardia. And so this dog was treated with antacids and had an immediate improvement and stopped coughing almost within a couple of days. I mentioned briefly ACE inhibitors in people as an important cause of cough. Again, 20–25% of patients, human patients, taking ACE inhibitors cough. And they cough because the ACE inhibitors are responsible for the breakdown of bradykinin. If we stop the breakdown of bradykinin, obviously we end up with more bradykinin, which is a precursor of arachidonic acid, and nitric oxide, which are sort of chemical mediators of inflammation, and they can cause cough in people. Now, do dogs cough with ACE inhibitors? It's not that common. Certainly, we don't, at least I believe, we don't reach 20-25% of patients, but we do see at least a couple of times a year, 2-3 times a year, dogs that will improve dramatically as soon as we remove the ACE inhibitors, and the mechanism must be exactly the same. Probably different in percentage due to different sensitivity, but it's exactly what happens in people. So another thing to remember when we want to investigate chronic cough in dogs. Cigarette smoking, another common cause of coughing in people, and we don't have enough information in dogs, but there are studies that show bronchial changes in dogs that are exposed to chronic exposure to cigarette smoke. But also has been there are studies that show the presence of high level of nicotines in the blood of these dogs, indicating that are exposed to chronic smoking in a household with people smoking, which indicate that these dogs actually inhale passively the smoke from their carriers. So another thing to remember is that when we investigate this cough is to find out whether these dogs live in a smoking environment, because that's certainly not helping these patients. Now let's move to Google again, and we change slightly the query, and we say common causes of coughing in dogs, and that's what we get. Kennel cough, which is the inflammation equivalent in people. Fungal infections, more common in America or Asia, but in Europe, fortunately, we don't have many fungal infections affecting the airways. Then we got heartworms, again, present in some European countries, distemper and so on. And then we got a new entry, heart disease and congestive heart failure. That was not present with the previous search when we're looking for common causes of coughing in people. So let's go and see why do dogs with cardiac disease cough? Very interesting question. And the cardiac cough has been reported for decades, and that's what I studied when I was at the university, but that's also what I investigated for the last 20 years. It's reported in most veterinary textbooks, but not human textbooks, attributed primarily to congestive heart failure, so the presence of fluid in the lungs. Also, this textbook report the dorsal elevation or compression of the trachea, dorsal elevation and compression of the left mainstem bronchus, edema of the bronchial mucosa as well reported as a possible cause. And why is this important? Because very often we have a dog with a murmur, coughing, that often prompt treatment for congestive heart failure, primarily diuretics. And that's why we need to understand exactly what's happening in these cases. Now, we have here a Doberman in overcongestive heart failure. The radiographs in the center is from this dog. It shows cardiomegaly, elevation of the trachea, congestion of the pulmonary veins, and this alveolar interstitial pattern invading most of the lung fields due to the presence of fluid in the lungs. Now, we know from earlier that there are not coughing receptors in the lower airways, in the smaller bronchi, bronchioles, and alveoli. So, for this reason, we should immediately think why the cough should not be evoked by this pulmonary edema. And indeed, you see the dog here is not coughing, but is dyspneic, which is a very intuitive response to the presence of fluid in the lungs. Dog is breathing with the neck extended, sometimes open mouth, the elbows abducted in order to facilitate the movements of the chest, and an abdominal effort to help the respiratory muscles to deal with this reduced perfusion. Now, the pulmonary edema has also been studied when in non-cardiac disease or non-cardiogenic edema in Swedish hunting dogs that, in this interesting report, can develop acute pulmonary edema during very intense hunting sessions. So this is a report, is nearly 20 years old, and you can see I highlighted the important facts. These were 16 hunting dogs with acute recurrent dyspnea following a hunting session due to non-cardiogenic pulmonary edema. And all these dogs had a cardiac workup performed by a cardiologist, so it's a pretty reliable situation where the heart is not involved. So if pulmonary edema does not cause cough in dogs in the absence of cardiac disease, why should pulmonary edema cause cough in dogs with cardiac disease? Pulmonary edema is pulmonary edema. And I leave the question open because we're going to answer this in a minute. The diagram here on the right side of the screen shows the bronchial circulation, which removes or eliminates the possibility of edema of the bronchial mucosa simply based on an anatomical situation. In other words, the bronchial mucosa is drained by the bronchial veins that then go to the azygos, so it goes to the right side of the heart. Our coughing dogs with heart failure tend to have left-sided failure, so go increased pressure in the left side. So that would not cause an increased pressure in the bronchial vein, and therefore would not cause bronchial edema as a cause of coughing. So again, that's another myth that's been removed from the equation. Now, in these videos, I have two coughing dogs, and the videos are fluoroscopic images of their airways. The fluoroscopy is a very useful technique to see in real time what happens in the airways of these patients that are coughing without any invasiveness. We can do it without any sedation, just a couple of minutes under the fluoroscopy tube to see what happens. And this is a Yorkshire Terrier, has a bronchial collapse and a tracheal collapse, we will see in the video, but also has a heart murmur. And the heart murmur is caused by marginal regurgitation, and this dog was put on diuretics for this reason. But in reality, if we look at the video, we understand why this dog coughs. Right, so that's the trachea of the dog. The cervical trachea, you see, opens, becomes white, and then it disappears when it collapses. And then when we move to the chest, the second, you will see that even the main stem bronchus collapses completely every time that the diaphragm moves forward. That's because of the compression, and the bronchus collapses. So this continuous friction is the cause of stimulation of mechanoreceptors and cough in these patients. In this video here, on the right side of the screen, we got another dog in congestive heart failure, but despite all the diuretic treatment, was not responding, was not improving, so still coughing. And you can see here, in this particular moment, you can see the bronchi are collapsing every time the heart beats. And that is a reason why these patients cough. Now, if the compression of these airways was the only reason of coughing, and due to the large heart, especially in the second video I just shown, then it would also apply to young patients like these patients with patent ductus arteriosus who have enormous hearts. The cardiomegaly in these puppies is really dramatic. And however, the presence of cardiomegaly in puppies very rarely causes cough. So the size of the heart is not sufficient to cause cough. This is a study that was published a few years ago to evaluate the utility of an unplugged device to occlude PDA. And I was lucky enough to be part of this study when I was at the University of Minnesota. And we had 18 patients in this study with PDA, and none of them was coughing. Only one actually was coughing, and that was because of kennel cough. And then as soon as the kennel cough disappeared, this patient underwent surgery as well. So if a big heart cannot cause cough in young patients, is probably because they have healthy airways. So in other words, we started at this point to think perhaps you need a combination in cardiac patient of a big heart and an underlying airway disease in order to see coughing. And these are spectacular images provided by an Italian colleague, Dr. Bottero, who described the or classified bronchomalacia in dogs. But the very first report of bronchomalacia was by Linnell Johnson from the University of Davis, California. So although in human medicine, bronchomalacia was a well-recognized problem, this has only been described in the last 10 years in veterinary medicine, particularly in dogs. You can see in the left side, you can see a dynamic collapse. On the right side, we see a static collapse, which is a more advanced condition. And you can see that because the bronchus loses, in bronchomalacia, loses strength, it becomes very flaccid. With the changes in thoracic pressure, these bronchi can collapse, and this is a continuous mechanical stimulation for cough. So that's what happens in most geriatric dogs, which might contribute to cough in cardiac disease. So this is a study that I performed several years ago, and was eventually published in the Journal of Veterinary Internal Medicine in 2013. The study was designed to evaluate the most important factor causing cough in dogs with mitral valve disease, whether it was pulmonary edema or airway disease or cardiomegaly, or a combination of these three. And we found that in 206 dogs with mitral valve disease, only 50% approximately cough. So it's not even that consistent problem in a cardiac patient, but 50% pretty much like tossing a coin. Of these 99 coughing dogs, we had 73%, so 3/4 with no congestive heart failure and 1/4 with congestive heart failure, thinking perhaps congestive heart failure is not that important in this context. And vice versa, we had 2/3 of dogs that were coughing in the presence of airway disease, and another 30% of dogs that were coughing in the absence of airway disease. But most importantly is that 100% of these dogs were coughing with congestive heart failure, were dyspneic. So dyspnea tachypnea is a consistent and almost inevitable sign in dogs with congestive heart failure. So we got a very specific sign, which is tachypnea dyspnea, versus a very non-consistent and also dubious sign associated with congestive heart failure, which is cough. This is the univariate analysis, so individual changes that we observed on X-rays, and you see that the increased heart size or the presence of airway disease can increase the risk of coughing, and the only parameter that we found was non-significant for evoking coughing in these dogs was indeed pulmonary edema. And even in the multivariate analysis, we had pulmonary edema still non-significant, not increase the risk of coughing, while the presence of airway disease or the presence of a big left atrium could significantly increase the risk of coughing. At this point, we had to find out whether it was airway disease alone or atrial enlargement alone responsible for cough, or an interaction between the two. And the image on the right side of the screen here shows the answer. So in the absence of airway disease, the presence of a big left atrium increases the risk of coughing by approximately 2.5 times. So it can still induce coughing, but not as much as when in the presence of airway disease, where you can see that the risk of coughing increases by nearly 11 times. So this is the answer. We got the airway disease and the cardiomegaly together. They act together to reach that famous threshold that we mentioned before in order to induce coughing. Many people come to me and say, well, I give furosemide and stop coughing. Yes, that's true. It can happen. And most likely it's because it reduces the left atrial pressure. So we reduce a little bit the stimulus, and so they stop coughing. It's not that we remove the pulmonary edema and they stop coughing for that reason. It's just we remove the pressure that is within the left atrium. But also don't forget that furosemide has anti-inflammatory properties and can also inhibit cough directly at the level of the coffee receptors, at the level of the larynx, at least in experimental animals. It can also induce bronchodilation, so reduce bronchospasm, but as I said before, this is less relevant in dogs. We will see that it would be more important in cats, and we will talk about bronchospasm later. One other thing we need to remember that very often it is a problem with our clients. Our clients describe cough what is not cough. So they come to us and say, my dog is coughing, and we just believe them. But look at these few examples. I've got here, for example, this dog, 12-year-old, sort of a golden retriever, Labrador cross, with 6-month history of coughing and a systolic murmur. And for this reason, the vet decided to start treatment for congestive heart failure with furosemide and benazir. But that's how the dog is coughing. So that's what the owner of this patient, the care of this patient, was describing cough. This is not cough. These are typical stridors due to, in this particular case, to laryngeal paralysis. And you see, this dog went on medication for congestive heart failure because of their own interpretation of the of coughing by the carer. And this is another very similar case. This is a Chihuahua with a 13-year-old with a 1 year history of coughing. Again, a loud murmur, and for this reason, the attending clinician decided to start treatment for congestive heart failure. But this dog is not coughing. This dog is again showing stridors, very large stridors, in this case due to a tracheal collapse. So you see 2 dogs that went on cardiac medications when they didn't need it. This is even a more interesting case because this dog was indeed in congestive heart failure, but was still coughing. And the reason why it was coughing is because of a wrong interpretation by his carer. So the dog is called Orlando, and you will see that he's not coughing. The dog is severely dyspneic and has a refractory heart failure. It's got pulmonary edema. And the carer thought that the sound of this gasping for air was coughing. But you see, you need to be very careful not to overinterpret or unnecessarily believe what our clients tell us, because we need to be very, very precise when a cough is described. So, there was a question earlier, why do dogs with a heart disease cough? Is it because they got pulmonary edema without dyspnea? That's incorrect. All dogs with pulmonary edema present with tachypnea and or dyspnea. This is very important. If there is not tachypnea and dyspnea, the dog is not in congestive heart failure. Pulmonary edema with dyspnea Well, yes, sometimes if it is a massive pulmonary edema, for example, as we see sometimes occasionally in large breed dogs, you've got a massive amount of fluid that forms and can flood into the airways, it can stimulate the coughing receptors, but this is not the typical presentation. Can cough be caused by cardiomegaly, but in the absence of airway disease, this is very unlikely. And you remember, I showed you puppies with massive hearts and they do not cough because they don't have the second component, the second contribution to cough, which is the presence of airway disease. So the last possibility, could it be cardiomegaly with airway disease? Yes, that is the correct answer. They need to have an underlying airway disease and cardiomegaly, which does not mean that they are in congestive heart failure. Very important not to be distracted by this clinical sign. So I prepared this short cartoon just to make sure that this is a very strong take-home message. So basically, a dog that is coughing but does not have dyspnea is not in congestive heart failure. So let's try not to overtreat these patients with furosemide if they don't need it. If we go back a little bit and we start thinking again about how well our clients describe cough in their patients, it is true, probably the majority of the cases they will. But there are situations where there is a very important misinterpretation. So for this reason, in the last few years, I always ask my clients to record a video of their coughing dogs. And this video very often can help because on presentation, perhaps they don't present the cough. So we need to induce it, but it's not the same as the spontaneous cough. So we need to see whether it is real cough or it's just a respiratory sound of different nature. So I now included the video recording in a sort of normal history. So history should include the video recording in order to understand exactly what happens in these situations. This is an algorithm that I designed. It's published in the last edition of the Ettinger textbook of internal medicine. And if you have access to this textbook, you will find this very helpful in order to identify the best action to take when you're dealing with a coughing patient, whether it is dog or cats. This is general, but you will see all the different strategies that you can implement in this workup. Right. So let's see why cough is important in our patient, both in people. Approximately 1 person out of 3 wakes up during the night because of cough, and there are approximately 20% of people coughing in winter months due to cold or flu, probably more now with COVID. And there are approximately 3 million prescriptions every year for cough remedies. And this doesn't take into account all the medications that we can buy over the counter, that are free of prescription. And it's a very common reason for seeking medical attention. So that's why cough can be so important. In our patients, we need to look at 3 major problems. Is it life-threatening? Should we block it? And when should we intervene? Well, we should only intervene when, for example, is in a big inhalation of a foreign body, the dog is suffocating, is coughing, but also suffocating. So obviously that's an emergency. But in all the other cases, it's never an emergency. We can consider this problem carefully and go to the bottom of the problem with a bit of logical approach. So the 5 questions that we need to consider, the 5 elements that we need to consider to determine if the cough is affecting quality of life in our patient, which is the only time when we should really intervene to inhibit cough, is when cough is interfering with sleeping. If cough is interfering with sleeping, the dogs wake up at night. Very often they also wake up their carers, and it becomes a problem for the dog and their carers. If they can't breathe because they are coughing all the time, that's another big issue. Or if they cannot eat or drink because every time they try to swallow something, they cough this water or food up, or when it causes discomfort, could be pain or discomfort or interfere with normal exercise. Very rarely we got more important problems like syncope, incontinence, fatigue. We do see them in a referral setting, but probably less likely so in a general practice. So the priority number one, once we have determined that we want to, it's an important problem, we want to address it, is to remove the primary cause. If the primary cause is obvious, like a foreign body can be retrieved, great. Or if it's a tumor growing in the lungs and causing cough, great, because we can intervene with surgery or chemotherapy, depending on the nature of the tumor. So that's always the primary one, the number one priority to address cough. But in the majority of cases, we're dealing with chronic cough, and so it's not something that we can remove easily. So we need to intervene with a conservative management. That's my first approach. Always try conservative management first before considering any drugs. Avoidance of irritants could be cigarette smoke, could be dust. In winter months, also could be the ashes coming from a fireplace or a wood burning stove, plug-in fragrances, sprays, all these materials can evoke cough by stimulating cough receptors. Then I always recommend the use of a harness rather than a collar when these dogs are taken out for a walk. Now is beautiful because in the last 2-3 years, we see a lot of dogs with a harness. Fortunately, the lead attached to the collar is slowly disappearing, which is something I've been fighting for the last 20 years. Now, finally, we see a lot of dogs with these smart harnesses going around. Weight control is another important intervention because fat can accumulate selectively even in the chest cavity, not just in the abdomen. The difference is that in the abdomen we can see it, in the chest we can't see fat accumulating. And therefore, because the chest cannot expand, this fat is compressing the airways, causing cough. So anecdotal reports say that if we reduce in obese patients the body weight by 10%, we achieve an improvement, clinical improvement in at least 50% of patients. And then we try to relieve obstruction of mucus by using humidification. And I always advocate the use of ultrasound humidifiers or cool mist. They're very efficient. And I'm going to spend a few words more in a minute. Now, when it comes to humidifiers, we got the option between the steam humidifiers, the classic humidifiers, or warm mist. They produce particles of approximately 150 microns. The problem with these humidifiers, they can predispose to bacterial growth because of the temperature, and the particles are bigger, so they may not necessarily reach the very deep parts of the airways. But cool mist ultrasonic humidifiers can produce particles that can go to very small diameter, to a micron or 20 microns, and therefore we can go much lower in the airways. But the big advantage is that the steam that is produced is cold, so it's not warm, and therefore there is less predisposition to bacterial growth. These humidifiers can be left plugged in all night, where in the room where the dog sleeps, and creates a very nice humidified environment that will help to fluidify the mucus and make this excretion be more mobile, can be coughed up more easily. So usually this dog coughs a little bit more in the first few days, but then they improve dramatically. Excellent system to reduce cough, even in people. So if you have cough in winter, this is fantastic for us too. They are very cheap, incredibly cheap. We can go from 20, 25 pounds on online shops, and so something that I constantly regularly recommend to my clients when they got a coughing patient. Coupage is something that we might consider in addition to that, which is just tapping the chest with a hand like a cup to produce a vibration that might potentially dislodge thick mucus from the wall of the bronchus in order to be coughed up more easily. If we do coupage, perhaps we do it at the end of the humidification. So if the humidifier is on all night, we do it early in the morning by tapping the chest of the dog for 10-20 seconds on each side. If all the conservative management does not provide satisfactory results within a few weeks, we can start considering centrally acting antitussive, but only if the cough is affecting the quality of life. Right, we got a lot of options here. These are drugs that will inhibit the cough at the level of the center of cough in the brain. Could be codeine, although I do have very inconsistent results with codeine. Butorphanol, a much better option, but more expensive, more difficult to administer. Now tablets are almost impossible to find, so it's only the injectable. And then we got other drugs that you can find in human health shops, like the dextromethorphan or Benylin. Dextromethorphan is an interesting drug, which again acts at the level of the brain, but with very inconsistent results. And then we got other drugs that we can mention briefly later. This is another interesting story here. We see on the bottom we got Benylin, which is dextromethorphan, coming in different forms for dry cough, for chesty cough, cough and colds, blah blah blah. And if you go to a health shop and you see these antitussives displayed on a shelf, go and read the ingredients because they are all identical. And the reason why they come in different colors is because it's all a psychological reaction. So some people believe that a red product works better than the green one. So it's a psychological marketing intervention that has produced very interesting results in human medicine. Obviously, dogs don't care about the color, and so therefore it doesn't make any difference. They're almost all identical, these products. Interestingly, there is a study several studies, but this is one of them in human medicine to see the results of cough remedies in children. And there was a study that compared the dextromethorphan with honey before going to bed. And they found actually that children getting honey instead of the cough suppressant before going to bed had better results. So there are no studies about use of honey in dogs, but perhaps something that we may want to consider in the future. Obviously, it needs to be first validated with a proper control study. Other drugs that are often used in treating cough in dogs, the xanthines, these are phosphodiesterase inhibitors like aminophylline or theophylline, very commonly used. Well, they don't do anything to reduce cough. I can tell you very clearly because they are bronchodilators. So they produce the relaxation of the smooth muscle of the airways, and they may work in cats. They may work in cats if the cough is caused by bronchospasm. As I said before, dogs do not have spontaneous bronchospasm. So there is nothing we can dilate there with these drugs. And what we see instead are all the side effects that can be quite nasty. They can cause tachycardia, they can cause insomnia. These dogs pace at night a lot. And they also need to be dosed very carefully. In theory, we should always measure the plasma theophylline level when we use these drugs, pretty much as we do with when we use digoxin, for example. We need to measure the digoxin level. And another group of drugs are the beta-2 receptor agonists. The beta-2 receptor agonists like salbutamol or albuterol, terbutaline or ventipulmin, which is caused clenbuterol is used primarily in horses, but just to add it to this list. Again, they are bronchodilators, and we don't have spontaneous bronchodilation in dogs, so bronchoconstriction in dogs, so we can't really dilate anything with these drugs. And what we see is primarily just the side effects. So my approach to bronchodilators is always very cautious. First of all, they've got larger airways compared to their body size, compared to other species. They don't have spontaneous bronchospasm. We need to remember that first, do no harm. We should never give a drug unless we know that it's not safe. And at the moment, believe me, there are no real studies to prove that these drugs are safe. And there was a nice review published a couple of years ago where the dog is described as the worst possible model to study asthma in people for this very reason, that they do not have spontaneous bronchospasm. And there is another study that was presented a few years ago at the ECVM conference in Amsterdam, where they try to induce bronchospasm in dogs using histamine or histamine like drugs. And these dogs were then treated with theophylline or salbutamol to prevent the bronchospasm. And both theophylline and salbutamol failed. And the reason is exactly the same, because of the size of the airways, most likely, and the fact that we do not have a spontaneous bronchospasm, so we don't have the typical asthma that we see in cats. Finally, I'd like to talk about mucolytic agents, because this is another approach to dissolve a little bit the mucus. I still prefer the humidifiers, the cool mist humidifiers, but both acetylcysteine and bromhexine have been used a lot in veterinary medicine, but at the moment there is not a strong evidence that they work. They may work in terms of reducing the consistency of the mucus, because they both work by breaking the disulfide bond of the mucus, so it becomes a little bit more, the molecule becomes a little bit more loose, and so the mucus itself becomes more fluid. But there is also another thing to consider, and which is also an important consideration in human patients. These drugs can cause a very rapid fluidification of the mucus, so that instead of being coughed up, can actually drip and fall in even lower part of the airways, making the situation even worse. So some pneumologists in human medicine are against the use of these drugs in this context. Right, so this was what I wanted to share with you today, and I hope you found this presentation interesting and or useful. And thank you very much for your attention.